Public dialogue and civic engagement play an important role in improving the health and well-being of Texans across our great state. That's why Blue Cross and Blue Shield of Texas is a proud supporter of free Texas Tribune events like the conversation you're about to see.
So, Ann, it occurred, Ann and Ovik, but I'll start with Ann. It occurred to me that late March, the 23rd of March of 2020, will be a decade since the implementation of the Affordable Care Act. A decade. So hard to believe. It's not exactly a mystery where each of you fall on this question, but let me put it in the terms that we normally hear in a political campaign. Are we better off than we were 10 years ago? Ann first and then Ovik.
That's a good question.
You have
Here's
hand
my
up.
mic. It's not attached to me, is
And
it?
you have an outside voice, but we probably need you to be mic'd. That's okay.
It's interesting that he said we. I think some of the problem that we have in Texas is that those of us who aren't among the 5 million uninsured are probably doing a lot better today, but the 5 million uninsured Texans aren't necessarily doing a heck of a lot better.
How about the state? Do you think, if you think about it as the royal we, how is the state doing?
Well, Texas, despite being one of only 14 and soon to be 13 with Kansas moving fast towards Medicaid expansion, despite having not done that Medicaid coverage for working poor adults, we still reduced our uninsured rate by 5 percentage points from 2013 to 2016. And we had never had even a single point of reduction in our uninsured rate for the entire time I've been doing this work, which is over 30 years. So we definitely made progress. And I think that a lot of the healthcare providers in the room will tell you that there is progress for them. But certainly we have a ton of additional work to do here in Texas in order to make the promise of Obamacare, the ACA, real for the folks who still aren't part of the system.
Before I go to Ovik, though, let me just be clear. We declined our uninsured rate despite not having expanded Medicaid, as opposed to because we did expand, right?
Exactly. Despite that, that increase was the result of more people getting individual coverage through the marketplace. We've got somewhere in the neighborhood of 1.6 million Texans who are getting individual coverage. That means they're not getting it through their job or through Medicaid. They're getting it direct from a health insurance company, and about half of them are getting subsidies through the ACA marketplace, and about half of them are paying full cost.
Ovik, she makes it sound great.
Well, first of all, Evan, let me just say what a pleasure it is to be here in this very important region of our state. I really appreciate the opportunity
Excellent
to visit.
beginning by a panelist. Very good.
By the way, Evan, there is something that I have been dying to ask you before we get to my answer to your question.
What's that?
You're one of the founders of the Texas Tribune, which
I
is
am.
celebrating its 10th anniversary. Can you explain to me why the Texas Tribune logo looks like New Mexico?
No, I cannot. I could explain
Something
it to
I've been
you,
curious
but then
about for a very long time.
I'd have to kill you if I told you why.
Okay.
Right? Yeah.
So with that out of the way,
Yeah.
thank you for that answer. And by the way, that was a very evasive answer.
Yes, it was.
I should
I wouldn't
know
let
for
me
the
get
record.
away with that. That's right. Yeah.
The short answer to your question is Evan, that some people are better off and some people are worse off. And the people who are better off, I think, are well described often by advocates for the law and and those who sympathize with the law. The people who are not better off or worse off are less well or aggressively or with alacrity described. And they fall into several categories. One category are those whose premiums have doubled or tripled due to the ACA. Basically, what the ACA did for people who buy insurance on their own is it made a group of people uninsured and made their health insurance less affordable in a way that made insurance affordable for others. So we talk a lot about, for example, the way the Obamacare covers people with pre-existing conditions. Well, there are lots of different ways to solve the problem of people who have pre-existing conditions and have trouble affording health insurance. The specific way Obamacare did it was to overcharge healthy people for their insurance. And so the end result has been a lot of people are priced out of the market under Obamacare that now have dropped out of the market or find insurance out of reach. So that's a big problem. Another big problem with Obamacare is that it raised taxes by about $2 trillion, or actually $1.2 trillion over a 10-year period, which not only affects the people who actually pay those taxes, but more importantly, has an effect on economic growth. That the ACA has been a drag on economic growth in ways that are very important, because at the end of the day, what has driven historically growth in health insurance take-up? It's been growth in the economy. Growth in the economy drives employment, and since half of Americans get health insurance through their job, economic growth is actually a really important engine of health insurance. In fact, we should mention that today the president signed into law the new U.S.-Mexico-Canada trade agreement, which we hope will have a positive effect on the economy of regions like this one, which could actually, therefore, have an effect on the degree to which people take up health insurance. So all that to say that it's not only important to look at the uninsured rate, it's important to look at the composition of the uninsured, and it's also important to look at the underlying cost of health care, which affects a lot of people who have insurance, but whose premiums and deductibles are going up, and wages are not growing as fast as they could be.
Anne was looking at you disapprovingly.
That never happens.
Yeah, I want her to lean into that vibe, but I want to say to her first, isn't he right that there have been negative effects of this?
Actually, and I think that the folks who, a lot of times what you hear folks who are opposed to Obamacare do is compare people's coverage that they had in 2012 and 2013 before the laws took effect, which may have been skimpy care that did not cover their pre-existing conditions, et cetera. And so where you have seen hefty price increases, it is because you went from coverage that would have left you bankrupt had you had a condition because it didn't actually cover a lot of your medical needs. So I'm not going to, I think part of what I want to focus us on in this conversation is that what the American people want is coverage that is comprehensive and that will give them financial security. So we are definitely, people want coverage that's not going to have any big holes in it, not going to have loopholes like surprise billing, and that is going to be somehow have a hard cap on how much of my income I'm going to have to put up in a worst case scenario. And for somebody in my income range, that might be 20 to 25% of my income in a bad year if I had a serious healthcare condition. For people at really low income, it's going to have to be something lower. That's what people want. People out there aren't worrying about the details of Bernie's bill versus somebody else's bill. That's what they want, and we can do that. Every other industrialized nation has found a way to do it, and that's what I want to talk about.
But the devil, of course, is in the details. So first of all, do you agree with Ovik that part of what's happened in the period of time in which the Affordable Care Act has been implemented is that taxes have gone up?
Taxes have gone up for a lot of reasons, and the Affordable Care Act was 100% paid for, largely, or one part of it being from taxes that industries came to the table and agreed to pay because they knew they were going to make buckets of money off of all the newly insured Americans.
Have both those things happened? Have the taxes been paid and have buttloads of money been made?
Certainly. If you, for example, just look at this year in the ACA marketplace in Texas, despite the fact that the federal government has done a lot of things to discourage marketplace enrollment, we actually had 5 of our 8 marketplace companies expand their capacity to work in Texas, and we're holding kind of steady on that. Not the kind of growth that maybe I would like to see to cover more uninsured Texans, but this has by no means been some kind of disaster for healthcare providers or for the health insurance industry.
Ovik, you went right to the negatives as you're apt to do here, but the fact is the numbers that Ann called out, the decline in the percentage of the population that was uninsured, the fact that up until recently at least, the number of uninsured children specifically in Texas was in decline. All those indicators, those measures, you will stipulate are good, right? There may be a cost to getting those to happen, but they've been good.
Well, first let me say, Evan, as you know, I'm a really happy, sunny, optimistic personality.
Yes, you are.
And I'm always looking for the good in every situation, including Obamacare.
Yeah.
And as I said, yes, there are some people who are better off as a result of Obamacare.
Right.
But I wrote at the time that Obamacare passed that Obamacare was going to lead to this problem of skyrocketing premiums, not because of skimpy plans, but because the regulations were so poorly designed that they would drive healthier and younger people out of the market and make their plans unaffordable. That is exactly what has happened. At the time when I wrote that, I got attacked. I was called a liar. I was called all sorts of things.
Right.
And it's played out exactly the way
So
I
you
described.
solve one problem, but in the course of doing so,
and that was
created others,
and
right?
what's important about that, Evan, is that was unnecessary. It did not have to be that way. It had to do with effectively the actuarial illiteracy of the people who designed the law that created that problem. It did not have to be done that way.
You could have designed it better.
Absolutely. And a lot of
Okay.
other people could have too, because this was a well understood problem among people who actually design and deliver insurance products. So
Is there a way to tell us how you would have made it better that
Yeah,
doesn't need
yeah,
translation
yeah.
services?
And take into account
let me
that
just,
Congress had a
it's
role
my
in
turn.
that,
Yeah.
too.
Here, as I mentioned, and I'm trying to. You could say I'm oversimplifying, but that's what one does in settings like this.
Yeah.
Basically, what Obamacare did was it said, in order to subsidize the cost of covering people who are sick and therefore have higher premiums, we're going to charge uninsured healthy people more for their health insurance. So again, you made one problem worse, the cost of insurance for uninsured healthy people, to make another problem better, which is the cost of health insurance for uninsured sick people. You did not have to do that. What you could have done instead is said, you know what? We're going to tax everybody and directly subsidize the cost of insurance for those who can't afford it, whether you're sick or healthy, whether you're incredibly poor or working poor, whatever. Basically, if you can't afford your health insurance, let's directly subsidize that. But the Democrats in Congress did not want to do that because they were concerned. The president himself in particular said, I will veto any bill that has a price tag of greater than $1 trillion over the first 10 years of the law's passage. And so that kind of arbitrary political decision led Congress to create this Rube Goldberg contraption that created huge problems for the millions of people who now are struggling to afford insurance because of that regulatory convoluted approach to covering the uninsured.
Man.
I would stipulate that, in fact, almost everything that is broken in the ACA, and I have a list, I'm happy to share with you about what needs to be fixed with it, is the result of political bargaining that was not enlightened with the kinds of structural concerns you have. For example, we were looking at a much more robust premium support and out-of-pocket support structure, subsidy structure, earlier in the development of that law. And now you have a situation where, if your income, I'm sorry, Evan, I'm going to do it again.
She's going to do it.
I can pull out the numbers if you like.
go ahead,
So around $65,000 a year would be like 2 times the poverty level, or 250% of the poverty level for a family of 4. Basically, once you get over 2.5 times the poverty line, you don't have any help with your out-of-pocket costs. You don't have any discount on your deductible in the ACA marketplace. And so you have a situation where our lowest income uninsured folks have a great deal, and then you fall off a cliff. And so that is a big chunk of our remaining uninsured are people at low to moderate incomes.
Who are just not poor enough.
And if we hadn't doubled the premiums, maybe a lot of those people could afford health insurance.
Yeah.
So that's a big part of the problem.
Well, I would argue that the American people are not interested in skimpy insurance. They want a decent standard of care for everybody, and nobody wants to have to, and they're willing to pay for it.
They weren't skimpy plans. They were. This is not an accurate representation of the kinds of plans that were in the market before. They were not skimpy plans. In fact, the plans had lower deductibles than the plan. The average silver plan deductible in Obamacare is $6,000. That is a very high deductible. But we were promised that Obamacare would make affordable. It was called the Affordable Care Act, right? That's not affordable for people who are making $20,000, $30,000 a year.
Well, and I am not nearly as interested in arguing about what we have to do to fix Obamacare, which I totally agree we need to do. I think the point is, I heard some fantastic experts, a huge fan of Elena Marks, huge fan of Lisa Kirsch, fans of the folks who are coming up on the next panels as well. Everything that they're doing to work on health, not health care, everything they're doing to bring down costs, to improve efficiency, to focus on outcomes. Those are all absolutely critical, both for community health and for a sustainable, cost of health care.
Yep.
But none of those, working on those, will not accidentally drag you into a system that provides everyone financial access to care that's not going to bankrupt them. That doesn't happen by accident. It will only happen if we try to make it happen, if we create that as part of the design. There's not a single industrialized country out there that just accidentally stumbled into universal coverage. You have to value that, and you have to build it into the system.
Right.
And then all of this other work makes the system work. So that's
Thoughtful,
where I'm
intentional,
coming from.
and deliberate. You have to do it in that way. Do you think it's fixable, the situation we have right now? If we were willing to agree that rather than overturn the system, get rid of it, and replace it with something else or nothing else, that we were willing to all pull together and work on fixing it, can it be fixed?
Absolutely, and probably most of the solutions that Ovik would recommend, I would agree with. It's just that he stopped short of what I'm proposing, which is, we essentially need a sliding scale guarantee of financial sustainability and financial protection for Americans to have guaranteed a decent common standard of health care.
And that's the biggest issue. That's the
he
biggest
wants
issue.
to focus on the costs, and they are important things to focus on. There's really legitimate issues with excessive profits and with inefficiencies. That's great, but just focusing on those is not going to get my 5 million people insured, and I'm not going to tell them you wait another 2 to 3 generations while we figure out how to fix all those problems.
Ovik,
Could I accurately represent my position?
I wish you would.
That would be great. So I support universal coverage. In fact, I am loud and proud about my embrace and crusade to ensure that every American has affordable health insurance, so that every American is protected from bankruptcy. These are things I talk about all the time.
Yep.
It's not merely that I'm focused on the cost, but the fact is, the reason why we don't have universal coverage today is because healthcare is too expensive in America. That's the fundamental reason. Because the United States already, per capita, subsidizes health insurance at a greater level than any other country in the world. So it's not merely that somehow we aren't spending enough to subsidize health. We subsidize to the tune of $7,000 per person in America. For all 330 million U.S. residents, we're subsidizing health care per person at $7,000, and yet we still don't have universal coverage. Why? Because the underlying cost of health care in America is extreme, and also because we take a lot of those dollars and use it to subsidize the cost of health insurance for wealthy and upper income people and not lower income people. So we have a highly regressive form of subsidizing health insurance and the two things are interrelated because that's a big part of why healthcare is so expensive in America. But those are the two problems we have to solve. And by the way, to solve them, drug companies, doctors, and hospitals will have to take in less revenue than they do today. And
They've got to be at the table, right? Yeah.
And that is the major obstacle to reform. And, we were talking in the last panel about the surprise billing legislation that passed the Texas legislature, and Dr.
Oliverson.
Yes, was mentioning what a triumph this was, and why this makes Texas better than Congress that can't get this done. Well, I have a bit of a different take on that, which is the reason why Texas got it done is because they basically made every concession to special interests to get it done. So what Texas did was say, well, basically we will cap out-of-pocket costs for patients and make insurers and hospitals go through an arbitration process, which basically is very much heavily weighted in favor of providers, i.e. higher prices, higher costs, which makes insurance more expensive and therefore less affordable for the people who need it the most. What Congress is trying to do is actually install a more market-based benchmark, which is more balanced and therefore has lower prices. And that's why it hasn't gone through, because the doctors and the private equity firms and the hospitals and all the profiteers are fighting them tooth and nail to prevent that from happening. So all that to say that just because you reduce out-of-pocket costs for patients doesn't mean you make insurance more affordable. You could actually make insurance less affordable if the underlying prices of healthcare go up as a result of those unintended consequences.
And before you respond to Ovik, you mentioned that you're for universal coverage, that in principle that's what you're for. What does that look like in your world? Because we hear terms like universal coverage tossed around by different people, and invariably different people mean different things, saying the same thing. So what does your version of universal coverage look like? Well,
what's really important to understand, Evan, is that we've been talking about, all the other industrialized countries in the world have universal health care. Actually, there is incredible heterogeneity, variation in the way the rest of the world, the rest of the industrialized world, has achieved universal coverage. So there are countries that do it in the Bernie Sanders way, in which the government is the sole insurance company. And there are countries that do it through a universal private system in which everybody shops for their own Obamacare-like or Medicare Advantage-like health insurance. Switzerland does it that way. Germany has a pretty much an all-private system.
Yep.
The Netherlands has an all-private system. So this is really important for people to understand because there are a lot of different ways to peel the onion of how you get everyone covered. And my whole thing is, let's actually explore and learn from those models of countries where the private sector is delivering the coverage. And what we're doing as a country to help make it affordable for everybody is to subsidize the cost of that coverage for the vulnerable populations that otherwise can't afford it.
So you haven't settled on one answer, but you're willing to look at what answers are out there and so do a best practices audit, basically, right?
Well, to draw it into more specifics, what we propose at my think tank, the Foundation for Research on Equal Opportunity, we have a whole very, very lengthy and detailed description of what our plan would look like. It's called Affordable Healthcare for Every Generation. And basically, again, the way I would summarize it in a glib way would be it's like the Obamacare exchanges for all or Medicare Advantage for all. So those systems in which basically everyone's shopping for coverage on their own using private insurers, and there's a graduated scale of subsidies that's steered towards more vulnerable populations, and there are certain brackets around what the benefit package looks like, but otherwise individuals, or in the case of Medicare Advantage seniors, have a lot of choices in who delivers that coverage to them, and those insurers are competing on value, price, and quality.
Okay. Anne, like a coiled snake, go. I see you want to get in this.
Well, actually, I was going to say that one of these other areas where we agree is the reason it is so hard, and people have asked me for years, why is it so hard for us to make progress on these issues, on cost and on coverage, and is because every single player in the system, regardless of whether they are labeled for-profit or nonprofit, are going to hold on to their current business model if it's working for them. So it is not easy to get rid of cost inefficiencies in the healthcare system. That's why somebody like me, you're going to look at my preference in terms of an approach to getting coverage for all Americans, is going to look more like Senator Klobuchar or Mayor Buttigieg. I don't want to take, there's a reason why President Obama didn't take on the entire healthcare industry and the entire health insurance industry and say we're going to change everything, we're going to get rid of profit overnight. That is simply too hard a political fight, even if it, in a very tabula rasa way, sounds real clean and the best way to do things.
Right. So you're not
Can I
Medicare
respond
for
to that,
all. You're
actually?
Medicare for all who want it, as the parlance of the moment goes.
I do not think that in any universal coverage system, the biggest problem is a tiny minority of people who, even if it's wildly affordable and comprehensive, are not going to want to participate. That's just, it's kind of a misleading issue. The problem with our folks who aren't covered today, if some of them are shut out of the system, we got, 1 million or close to 1 million uninsured adults in Texas who do not qualify for the marketplace because they have a family income below the poverty line, and we don't have Medicaid expansion. And you can't get ACA subsidies if you're below the poverty line. A lot of our elected officials don't understand that. We also have people who are excluded by a completely, boner kind of thing that the Congress did with the ACA, which was called the family glitch, which is where if my premium is 100% paid by my employer, it doesn't matter how much of my income I have to pay to cover my spouse and my kids, they can't get subsidies in the marketplace. So we have a number of things, not just for the poorest of the poor, that we need to work on. And again, I just don't think, I've been doing this for over 30 years. President Nixon proposed a universal coverage program. I just think we have the information we need. It is time for a country to make a commitment, to take that next step and close those gaps.
Ovik.
Yeah, so I'm really glad that Anne took the conversation the direction she did, because this is a really important aspect of this whole debate that I really want to highlight. We're used to thinking of healthcare in a kind of ideological way. Are you for a more government-run system where the government is the insurance company, or are you for, like I am, a more private-oriented approach where the private sector is delivering the benefit? Leaving aside the ideology, here's why I think I can persuade all of you that the private sector approach is better. Every time a legislator or a regulator or a president has tried to say, you know what, the cost of hospital care in this country is too high, I want to whack it. Whether it's Medicare for all or it is a public option like Buttigieg and Biden and others support, I guarantee you that if there's a President Buttigieg in 2021, and he proposes a public option that pays Medicare rates instead of what private insurers pay, which is basically 3x Medicare. What's going to happen? Every hospital in America is going to descend on Washington and argue that they're going to collapse and fall apart and die unless this piece of legislation is killed. And it'll never happen. Or the public option will basically pay 3x Medicare like the private insurers do, and it will have no impact on cost. So if you put the decision in the government's hands, whether it's the legislature or CMS, the federal agency that runs Medicare, whoever it is, it's going to become political. It's going to be, and the battle is going to be fought over lobbying. Who's got the best lobbyists? And the best lobbyists are always employed by the people who actually are making the $3 trillion we spend on healthcare today, which is not you and me, Evan. So the point I'm trying to make is that if you put the decision in the hand of government, say, we're going to rely on government to reduce the costs, in our system, in the United States, this is different in France and Germany or wherever, in the United States, thanks to the First Amendment, it is not possible for the government to make that decision in a way that once you put the decisions in the hand of the government is not capable, because of the power of lobbyists, to reduce the cost of healthcare. However, if you actually put the power in the hands of 330 million Americans, and those Americans say, you know what? If I have a choice between 10 different insurance plans and this one has a lower premium even though it's covering the same benefits as all the others, and that's because they've negotiated a better and tougher deal with the local hospitals and doctors and whatever, I'm going to choose that plan and reward that plan with my business. What do you think that does? That leads to a consumer-driven approach to reducing the cost of healthcare, just like we've seen when we deregulated the airlines, just like we've seen when we shop for so many other important and complex services and products around the country. We should have more faith in the consumers to overcome the power of lobbyists. We've learned through decades of experience that government and politicians do not have the power or capability or will to overcome lobbyists.
How does having a public option competing with private insurers not still achieve that goal? If the private insurers are doing a better job?
It would if the public option could actually become law, but it won't, because a public option that actually competed with insurers in the sense of capping what people pay or how that insurance plan, in the case of the public option, reimburses hospitals and doctors. If it's reimbursing hospitals and doctors at a lower rate than private insurers, who's going to object to the enactment of a public option? Every doctor and every hospital in America.
The lobby
and so
will
it's never going to
descend,
happen,
right? Yeah.
is what I'm trying to say.
Right.
The public option, if it actually were to get through Congress, by the time it got through that, even if it passed somehow, it would be so watered down and weakened and riddled with loopholes that it basically would have no effect.
So go to the other end then. If the public option compared to private insurance is going to get beaten down, why not just go full on Bernie Sanders and just say, I'm not advocating necessarily for this, I'm simply asking as an exercise here, why not just say private insurance gone, we're going to force everybody to participate in some kind of a public deal or a government-run deal, and that's it?
Yeah, look, I mean, as I said, it's even less workable politically, right? So this is the problem. It's theoretically, if you had Medicare for all, theoretically, if you had a real public option that really had teeth and was robust, those things could reduce the overall amount we spend as a country on healthcare. It may have other negative side effects that I don't want to bother with right now, but it could do that. The problem is that will never happen because lobbyists will never allow it to happen, and lobbyists have too much power in our system.
The same lobbyists who would object in the other scenario would object on steroids in this scenario, basically.
Exactly.
Right.
Whereas if you have 330 million consumers independently making decisions, say, you know what, I'm going to choose to fly Southwest instead of United. You know, that sort of decision-making process that didn't exist prior to the deregulation of the airlines in the late 70s.
Right.
That has made airline travel massively, accessible to so many people. The same principle of economics can apply to health insurance if we allowed it to.
And can you drain the swamp enough to get a public option passed?
I don't know exactly what it would look like, but I think one of the things that occurs to me is, in Texas, we have 4.2 million people covered by Medicaid, and with a very robust partnership, almost 100% of those people are covered through private risk-based HMOs, and those providers, despite reimbursement that's for many things below what Medicare would pay, not just below what the private sector would pay, they still participate. It's important. We have a health insurance industry that literally takes home over $500 million in clear profits just from Texas Medicaid every year. So, I think that there's a lot of complexity there that I just can't immediately buy, your prescription or your projection that there's no way in hell we can get to a public option that can actually live up to its value. And I think that one of the things that we have to remember when we look at those horrible graphs that show the United States spending way more per capita on healthcare than any other industrialized country, and then having worse outcomes, that one of the things that we're looking at, and you've hinted at it, although you don't use the word profit a lot, is that one of the pieces that has to suffer are those profit margins. I mean, you talked about costs coming down in several sectors in order to get to efficiency and cost, but that's one of the things we have to look at is, are we willing to back away from absolutely no limits on profit margins in healthcare, including even in our state-funded Medicaid program?
Let me ask Ann a question asked often of people who are advocating for either a public option or full-on Medicare for all. How are you going to pay for it? Who is going to be on the losing end of this to finance the additional spending by government to make this available? I'm asking you.
But the first stipulation was, you ask people who are for Medicare for all or for what?
Well, I'm saying that whether you go halfway or all the way toward government bearing a larger share of the cost to provide coverage to people who don't have it, presumably that cost is going to really be borne by somebody outside of government. Is there going to be, for instance, as has been proposed, a wealth tax? Like, what do you?
I have no problem.
How are we going to
with
pay for this?
Certain wealth taxes. My organization is strongly in favor of progressive tax structures.
You don't say, really? Is it? I didn't know that.
And just to toss in a little, Texas. If we were collecting state taxes today, at the same percentage of state income that we were in 1991, we would have had another $13 billion a year
You're
to put
talking about
into
an
our
income
state
tax.
budget. No,
Oh.
just the taxes that we have. We shrunk the pie in Texas over the last 2 decades.
So had we not done that, we would have
had another $13 billion. So this is
Right.
part of what we're dealing with at the federal level, is that every time we shrink the pie, that makes it a little harder
Fewer
to
resources
fund
available.
something new. But
Right.
I think one thing that Ovik and I would both agree on is, when you look at that graph that shows us spending twice as much per American on health care, despite the fact so many are uninsured and despite the fact that we don't have great public health outcomes, the conclusion can reasonably be made that there actually may be enough money in the system right now. Now, I certainly think that any kind of universal health care system can and should be supported by a mixture of taxes and direct payment out of household incomes. Although an economist will tell you all money comes from household incomes.
Well, that's going to be litigated in the course of the
No,
campaign.
but
It's being
basically what I'm
litigated
saying
now.
is,
Right, yeah.
I don't mind a system where, like I said, I'm on the hook for 20 to 25% of my income in a really bad year. Hopefully it's going to be significantly lower than that. For somebody who is a working poor family, it's going to have to be more like 5% of their income, because they don't
Right.
have any flex.
Right.
But I think, there is the money in the system, and unfortunately, it's not at all easy to get the kinds of efficiencies that we do agree on need to be pursued, because everyone's going to try to protect their profits.
Ovik, you advised the Republican who wanted to be president in 2012 on this issue, was not successful, right? You advised 2 different Republicans who wanted to be president in 2016 on this issue. They were not successful. Let's talk about the guy who was successful in 2016 and is now the president. His position on health care over the course of the last 3 years has been largely to say we need to unbuild the Affordable Care Act, bit by bit, right?
Well, it's very interesting. The president, when he campaigned in the Republican primary in 2016, 2015, I'll never forget in the first debate, the first GOP debate in Cleveland in the summer of 15, there were 20 candidates on it. I think they split up to 10 by two stages of 10.
Adult table and the kids table, right?
And he went out of his way to say, when someone criticized him for praising the Scottish healthcare system in one of his books, he said, "My healthcare plan will cover everybody. We have to take care of our people. I want every American to have health insurance." And he insisted all the way through to January, February of 2017 that his beautiful healthcare plan would cover everybody.
How'd that work out for him?
Well, I think we all know the answer to that, but the point I'm trying to make is that what's really interesting to me about the president is that he actually broke from Republican orthodoxy on this issue when he was campaigning. When he had, in a sense, arguably the greatest interest, selfishly not to, in the sense that when you're trying to win a Republican primary, do you want to really, be out of the mainstream of what the other candidates are saying? Generally, the instinct of most politicians is not to, right? But he said, no, I don't care what. I know this is not a. He said He's literally said, I know this is not a traditional Republican position, but I don't care.
Right.
I want every American to have health insurance. And then what happened is he got to the White House and he outsourced his health care plan to Paul Ryan, and Paul Ryan had a very different view.
Different view, right.
And again, we all know the history that came from that. But all that to say that it has been my hope ever since the president got elected. Did I turn off my mic? No.
It's okay.
It's been my hope ever since the president got elected that he rediscover that promise.
Right.
And certainly in my conversations with the president's team, I have made I've done my part to reiterate
You've
that.
made that known. Well, let me read you the president's tweet from 16 days ago. He thinks he's still the candidate in 2016 who was talking about that. This was the president's tweet. I was the person who saved pre-existing conditions in your health care. We can just stop right there and fact check that if you want.
Well, I mean, there is nothing that is actually. It's important to fact check that, which is there is this kind of narrative in the media that somehow Republicans took away the Obamacare protections for pre-existing conditions. They have not. They are still the law of the land, and they always have been.
But I think the narrative was that they wanted to. They just didn't succeed at it.
No, that's not true. Actually, the both the House and the Senate bills that Republicans were considering to quote-unquote repeal and replace Obamacare did not touch the provision in Obamacare that talks about requiring insurers to offer coverage to everyone regardless of pre-existing conditions. That is an absolute fact.
So when the president says, I will always protect, in the second part of this tweet, I will always protect your pre-existing conditions, the Democrats will not, basically as a way to set up the frame for this in the campaign. Do you think the president's accurate about that?
Well, the way I would put it is different than the president. What I would say is the approach that Obamacare took was we're going to protect people with pre-existing conditions by making it much harder for uninsured healthy people to afford health insurance. And our plan should be, if I were advising the president, our plan should be to actually solve that problem and to say, you know what, we are going to make sure that people with pre-existing conditions can afford health insurance, and we're also going to make sure that healthy Americans can afford health insurance, because there are a lot of them too.
And you're for pre-existing conditions, right?
Yes, and mom and apple pie.
You're going to vote for
I'm
the president.
against pre-existing conditions.
Will you vote?
But
You are?
I mean, I don't want people
No,
to have
I think
them.
the thing that
I didn't mean that.
in 2017, I think the thing that got lost in a lot of the pre-existing condition discussions is it's not meaningful just to say I'm going to tell all the insurers they can't deny you for pre-existing conditions. It also has to say you're not going to be charged anymore because of your pre-existing condition, and you also have to have a sliding scale subsidy system so that everyone can afford to buy the coverage. And if you don't keep all of those,
it's not enough to just say I'm for that. Very quickly, we're going to go to questions in about 2 or 3 minutes, and I'll encourage you to line up at the microphone. I want to ask you about a story in the Washington Post yesterday that I alluded to earlier in our panel, and that is this is the headline in the Washington Post yesterday: Trump administration to offer states Medicaid block grant option. Here is the lead of that story. Top Trump administration health officials are inviting states to convert part of Medicaid into a block grant, a longtime conservative goal rejected more than 2 years ago. This will apparently be announced tomorrow. This is going to happen. Good thing or a bad thing, Ann?
I'll have to persevere. Well, okay. Good thing or bad thing? The first thing to understand is they're not proposing to allow states to block grant the entire $43 billion a year Texas Medicaid program. They're going to allow them to potentially have a block grant-like structure just for the Medicaid expansion population that we don't cover in Texas, which is estimated to pick up about 1.5 million uninsured adults in Texas. So that's the first thing to understand.
Right.
I think it will. Another thing to understand is it will be immediately challenged in the courts, just like
everything else,
excluding Planned Parenthood,
in life,
just
right,
like the Affordable Care Act,
right,
just like the public charge rule. I mean, so it is not at all clear that the administration has the flexibility to allow that as something you can do under a waiver. That'll be challenged. I think while it is absolutely not in any way, shape, or form the best way, I don't know why the parents of our kids on Medicaid somehow have to have their health care delivered through a block grant while their kids can be, assured the entitlement of matching funds to the state of Texas, which is part of the Medicaid program. I don't think there's a rationale for it. If it happens and it's enough to get our state leadership to stop blocking coverage for, like I said, mostly working families of very low-income adults,
Yep.
disproportionately in this part of the state, then I would welcome that discussion.
Ovic, do you like this block grant plan or not?
First of all, let me reiterate that the plan that's going to be rolled out tomorrow, I would expect that plan will be about the Medicaid expansion population, not about the legacy Medicaid program. And I, as an aside, I want to mention that, Ann just mentioned, well, there's 5 million uninsured people and 1.5 million would be on the Medicaid expansion. It's really important to understand that in terms of the actual coverage expansion effect of expanding Medicaid in Texas, it would not be 1.5 million. It'd be 750,000. Because half the people who would qualify for the Medicaid expansion actually already have other forms of insurance, either through Obamacare or through employee-based coverage. No, well, if the Kaiser Family Foundation estimates that, which is the most reliable source of these numbers, 750,000 people fall into the Medicaid coverage gap, meaning the Medicaid expansion would cover them, and it wouldn't be redundant coverage, meaning they don't have another source of coverage. I've looked this up many times. It's 750,000. So
And the other 750,000?
Let me finish. So that's 15% of the overall uninsured population in Texas. We should also remember that 1.6 million of the residents in Texas are undocumented immigrants who are not eligible for Medicaid or Obamacare or Medicare or any of the other subsidies that we're talking about here. So we talk a lot about Medicaid expansion at Texas Tribune events. You were joking earlier about we always talk about nurse practitioners. We always talk about Medicaid expansion. And you'd have the impression, by how much we talk about Medicaid expansion, that somehow that we would solve all our problems if we just expanded Medicaid. No. Actually, the uninsured rate would only go down by about 15% of the 100%, meaning like of the 5 million, only 750,000 would have coverage. And the quality of that coverage, et cetera, is going to be challenging because the fact is this 55-year-old statute, the Medicaid statute, really limits the tools that states have to manage their Medicaid programs. And then this going back to your question, Evan, this is the point that what it's being billed as the block grant, regulation or reform or initiative from the White House. They cannot propose anything that goes outside of what the Medicaid law passed by Congress in 1965, the Title 19 of the Social Security Act, what that allows, right? So what we're basically likely to see is something that basically creates a one-stop shop for all the waivers and flexibilities that this administration and others before it have allowed states to take on, and kind of simplify the process for taking on those waivers and create sort of a back-end a structure for having a fiscal accountability to that for the states. And they're going to call that, or other people may call that, a block grant. But you shouldn't expect that this is going to be some sort of transformative,
Massive
different
overhaul,
Medicaid
right.
program than the one
Got
that
it.
we already see.
All right, I'm going to leave here, by the way, and look up which number, 750,000 or 1.5.
Please let me
is right.
explain it.
All right.
The,
And then I want to ask
the
the question.
term,
Yeah.
the coverage gap, as Kaiser uses it, refers only to the subset of the Medicaid expansion that's below the poverty line, and they are called that because they are excluded from the marketplace subsidies. The Medicaid expansion
That's
would
exactly
also,
what I said.
The Medicaid expansion would also include people between 100 and 138% of poverty
Who get coverage under Obamacare today,
who can
heavily
get coverage,
subsidized in Texas,
who can get heavily subsidized coverage
who
under
are
Obamacare.
100% eligible
They are
for that
eligible,
coverage.
but the number 1.5 million, the other 750,000 are uninsured adults in that income range, 100 to 138. Now, you may quibble that those people should have signed up for Obamacare, and that may be a legitimate conversation, which, of course, as you know, we've slashed marketing and slashed outreach and slashed applications. But those are people who would be covered under Medicaid
But there are
expansion.
lots of people, as has been noted earlier in this panel, who are eligible for Medicaid in Texas today and don't sign up for
There
it. So
actually
if you're going to
aren't
count
lots.
those, if you're going to count those
We-
people as somehow
All right, I'm
magically
going to
covered-
step in. I'm going
I
to
just-
blow.
you
I'm
just
going to
can't do
blow
that.
the blow
That's
the
not- that's
whistle.
not math.
Wear the black and white stripes. I'm going to blow the whistle. As much as I'm
Okay.
tempted to say that my definition of a great Texas Tribune event is a fight over the definition of coverage gap. This is great. We're going to go ahead. Right there, ma'am.
Good afternoon.
Oh, I know your question. This is going to be a good question.
I'm Elaine Hernandez, and I do have private health insurance through my employer and Medicare, but I'm still afraid of bankruptcy. My question to you today is, as we were examining this morning some models in other states of health care that appear to be successful, I look to my president and our elected, federal elected representatives at their health care package and say, is there any way that 330 million Americans could buy into that health care package?
A great question. And first of all, I would say that the models that both federal employees, the way federal employees get coverage, is not that different from Obamacare or Medicare Advantage. The state employees in Texas and most other states are run like a large self-insured company where the state basically contracts with a private insurer to offer health benefits to state employees. I would say, frankly, that I don't. While those plans are very generous and heavily subsidized by the taxpayer, I wouldn't say that in terms of the underlying cost of the health care that's being delivered, that it's better or superior to the health care that's available outside of government employees. Basically, it's incredibly expensive. There's no incentive to keep costs down, and also requires a lot of scrutiny of the cost controls. In fact, one thing I would encourage Texas to do, if it really wants to get its budget under control and have more room to, say, pay primary care doctors and Medicaid more money, for example, would be to say, if you're an employee of the state of Texas and you have insurance through the state of Texas, we're going to pay Medicare rates for that care. If you did that, the amount of money that Texas taxpayers would save would be enormous.
How much? What does enormous mean in that case?
It would be at least in the tens of millions of dollars. Depending on exactly whether you went for all, whether you do state and local employees or just state. But it could be significant, and it could be enough to create room for other needed health care
and you like
spending.
that? Do you like that plan?
I'd have to see the numbers. I mean, remember, we have a $43 billion Medicaid program, so
Right. But it might
You gotta
give you,
start somewhere.
but to Ovik's point, it might give you the latitude, for instance, to up the reimbursement. We had a conversation in the last panel about the reimbursement rates for Medicaid. You might have some money available to do that, which in turn would incentivize providers to take on more Medicaid patients.
I am all in favor of that. I'm just a number like tens of millions is very, very minimal.
It's
in
very
a Medicaid
attractive
setting.
in the abstract, though, isn't it? Tens of millions. I like the sound.
Well,
of
I'm not going to say it's going to save $90 billion because it's
No,
not. But
right.
could it save?
But
Could it save a
somewhere
meaningful
south of
amount?
And again-
Is what the state of Texas pays for the health benefits of state employees a significant line item in the budget? Yes.
Watch out.
Sure.
We're weaponizing the Q&A portion by having somebody who actually knows something ask a question. Go ahead.
Elena Marks, Episcopal Health Foundation. So I was really excited to see both of you talk about that the goal is universal coverage, and when we look internationally, there are lots and lots of different ways to do that, and that a distinction between our country and all of those others is that we are spending at least 50% more than the next highest on health care costs. There's another factor in that equation that I think you can't leave out if you want to correlate it with health outcomes, life expectancy, infant mortality, obesity rates, and that is the OECD countries' expenditures on what they would call internationally social care, what we might call social determinants or human and family-friendly policies. They spend a lot of money on that, and if you look at the two categories combined, healthcare expenditures and social care expenditures, the U.S. is on the higher side, but it's not really an outlier. The difference is we are way overspending compared to all those other countries in the medical care part, and we are way underspending compared to those countries in the social care part.
Can you give an example or two of social determinants as you're talking about them?
Environmental cleanliness, poverty, affordable housing, family leave.
Right. So it's pay me now or pay me later, basically, is the situation.
It's an investment in humans so that they live a healthy life versus an investment in what you do once the humans are broken.
Right. Ovik, it seems
Lena,
like it'd be fiscally conservative to do that on the front end as opposed to the back end, right?
So I'll agree and disagree with you, Elena, in this way that it is true that European countries, for example, spend more on, say, classical welfare spending than the United States does, relatively speaking, and we spend a lot more subsidizing health care relative to those countries, as we talked about earlier. But when we talk about social determinants of health, it's interesting. If you actually dig into what really correlates to health outcomes, one of the most important correlators to health outcomes, or one of the most important social determinants that correlates to health outcomes, is educational attainment. Do you have a high school diploma? Do you have a college degree? If you do, that's highly associated with strong health outcomes. And you know what's interesting? K through 12 per pupil spending in the United States is actually just like healthcare. We spend way more than all those Europeans do on K through 12 schooling and education. So we're arguably just as inefficient with just as poor outcomes, relatively speaking, on the K through 12 education front as we are on the healthcare front. So I would say, yes, it's true. We don't know the correlation on the welfare. It's interesting, and it's theoretically an interesting argument. But I would say the thing we really got to focus on is how we're failing on education, both in terms of outcomes and per pupil spending.
Ann.
So I would say that there are social determinants of education, and that if we are putting all of our money into buildings, equipment, teachers, technology, et cetera, and we have students who are not prepared to learn because of the environments in which they live, we are wasting our money there as well. We're not investing in our people.
Right,
Yeah,
okay.
sure.
Ann.
Honestly, I just want to plug those of you who are interested in this discussion. If you haven't looked at the Episcopal Health Foundation website, they have worked with Kaiser and independently to do some excellent polling of how Texans feel about health care and about the role of government in health care. So I would say check that out. Yeah. And in case I don't get another chance to talk.
You will.
Okay. Well, I want to mention one thing that as I've said, unfortunately, most of the wonderful reps who were here for the previous panel aren't with us anymore. They did do some amazing good stuff last session for people who have health insurance. The surprise billing was a wonderful step forward for people who have insurance. We had some great new protections added to Medicaid managed care. They'll increase accountability there. But one of the things that a lot of us are feeling is that next session needs to be the time they actually pay attention to coverage and do something about coverage. And I know Representative Howard did a great job of mentioning a couple of opportunities that they missed last session. So I have over on the table a big stack of cards from a campaign called Sick of It, Texas. And what we're sick of it is being last and having so many uninsured and not having enough solutions. So please follow up with me afterwards if you're interested in getting one of those.
We've got time for one more very quick question and very quick answer before our panel is over, sir.
Oh, just a quick comment. I agree with the social determinants of health. I'm Dr. Harkless. I'm the interim podiatry dean at the UTRGV. And as a foot doctor looking at risk factors for amputation, the social determinants, we did that called the University of Texas Wound and Risk System in the decade of the 90s. But what we're doing now is looking at the social determinants. There was an October 1 issue of New England Journal of Medicine of 14. It was a perspectives article, says becoming a physician, perspectives on the social history. There were 6 domains. It was about 6, 8 things on each one of those domains. That's where we mess up. And I'm talking about 43 years of practicing medicine at the root level in a county hospital where you have the sickest people.
Well, let me just say, there was the theme of Elena's question, and the question was just asked in terms of, we have to invest in our communities. Yes, okay, sure, we have to invest in our communities. We have to remember, though, I think too often in settings like this, the conversation is about dollars. Well, we have to spend more, and then the community will be better off, right? Instead of, and what we ignore is a lot of the things like the legacy of slavery and segregation, like the fact that our housing policy effectively segregates low-income people into communities where their property taxes can't adequately fund services because upper-income communities don't want to allow low-income people into their communities through high-density housing and other things. And this is a big problem in places like Austin where both of us live. So there's a lot that particularly cities can do to open up upper income parts of their counties and their metropolitan areas to higher density housing and a more economically diverse community. And that is a big reason why we're having the problems around. There's an enormous amount of research now. Raj Chetty and others are describing how economic segregation, the fact that poor people all live together and rich people all live together, is a bigger driver of this problem than, say, the government spending X dollars on X thing in X place.
Okay, good place to end. A smart conversation with two smart people. Appreciate the different perspectives and the civility of the conversation. Please give them both a hand, Ann Dunkelberg and Ovik Roy. We'll take a short break and be back with our last panel. Thanks very much.